time-lapse as a tool in the embryology lab is moving from a nice to have toward a must have. And I think that that is really rooted in the desire to make what we do in the embryology lab more objective rather than subjective. So more precise embryo assessment. We also want an AI-driven embryo selection tools, which time-lapse makes possible. And of course, there's the aspect of undisturbed culture conditions that are also important. So yes, I agree that we are moving from time-lapse incubation being nice to have toward a must-have.
Scalability and standardization. Are time-lapse incubators a nice-to-have or a must-have? Every time I ask this of embryologists, I get some version of the same answer. There's nuance, but it's a must-have, they say. The nuance? Obviously, EmbryoScopes aren't a panacea, right? Some benefits might be more important than others. The clinical improvements may only be incremental right now. Even my guests on this episode say that some labs will be just fine without them. And yet virtually every embryologist I've asked has said time-lapse incubators are a must-have for the future of the standard of IVF care. Why? Thanks to my guests, 3 different IVF lab directors, Ms. Christine Yee, Dr. Mina Alikani, Professor Alison Campbell, I now understand why. It's all about standardization and consequently scalability. How can you scale your fertility clinic or network if you haven't standardized your best practices across labs? Listen to how each of my guests keep coming back to this need for standardization. Christine Yee shares how she uses EmbryoScopes to manage standards between one small team on the East Coast and another on the West Coast. She talks about how she uses EmbryoScopes to grow IVF volumes with a small team because you probably can't hire a bunch of extra embryologists either. She shares how she uses EmbryoScope to maximize the space she has in a small IVF lab because you're probably working with limited space too. Mina Alikani talks about the necessity of standardization as the operative shared word in the concept of standard of care. She reframes the question for all the C-suite listening. She talks about her first uses of EmbryoScope, things that she had never seen before in an embryo. Alison Campbell shares how CARE Fertility invested £1 million in a complete embryology system that also included EmbryoScopes, and how that system saves 6 months of embryology time per year. They talk about how their IVF labs scale care by reducing time for FERT checks, embryo assessments, and integrating with AI to automate annotation. They each share mistakes they would avoid and what they would do to take advantage of an offer that Vitrolife has for eligible clinics to try EmbryoScope for free for 4 months. Listen to what these lab directors have to say, and then give it a try for free for 4 months to see if you can replicate the success that they were each able to standardize. Contact Vitrolife to see if your clinic is eligible, and enjoy this conversation about the standardization of best practices in the IVF lab with Ms. Christine Yee, Dr. Mina Alikani, and Professor Alison Campbell.
Today's episode is paid content from our feature sponsor, who helps Inside Reproductive Health to deliver information for free to you. Here, the advertiser has editorial control. Feature sponsorship is not an endorsement and does not necessarily reflect the views of Inside Reproductive Health.
Ms. Yee, Christine, Dr. Alikani, Mina, welcome to the Inside Reproductive Health podcast. And Professor Campbell, Alison, welcome back for your 3rd time, I believe, on the Inside Reproductive Health podcast.
Thank you very much for having me. Yeah, thanks. It's great to be back.
Thank you.
Mina, I see different embryologists starting to have a consensus. One of our audience members said that time-lapse imaging in the IVF lab is increasingly moving from a nice-to-have to a must-have. What do you suspect that person means? Do you share that view, and why?
I actually do share that view. I think that time-lapse as a tool in the embryology lab is moving from a nice to have toward a must have. And I think that that is really rooted in the desire to make what we do in the embryology lab more objective rather than subjective. so more precise embryo assessment. We also want an AI-driven embryo selection tools, which time-lapse makes possible. And of course, there's the aspect of undisturbed culture conditions that are also important. So yes, I agree that we are moving from time-lapse incubation being nice to have toward a must-have.
Christine, you're nodding your head.
Yes, I would agree with that. I also think there is the aspect of the procedures that are going on in the laboratory and being able to take out a portion of observing the embryos and evaluating them out of the physical laboratory allows that space to be used for other techniques. The world of fertility is just growing and laboratories are getting busier and busier. It's a big overhead in general, each square footage of your lab compared to other areas of the clinic. So being able to remotely meaning outside of the laboratory, perform some of those techniques that we would typically need a microscope station for, just makes it possible to do more in that same space and for the embryologist to have more area to work in.
I want to go into each of these buckets as we talk more today, the clinical outcome side, the workload improvement side. Alison, do you feel that it is neck and neck between those two of what's tipping the balance towards time-lapse becoming the standard, or is it more about one of those buckets than the other?
I think there are so many benefits, as we've heard, but I think in terms of nice to have, best to have, I think it's a much better system. And I think the main benefit, if I had to choose one bucket, would probably be embryo selection, assessment and selection together. Because as we know, we've heard the human is so subjective, and this information that we get from the time-lapse systems allows much more objectivity and much more information. You can't compare the quantity of information you get from a snapshot, morphological, microscopical evaluation, and the time-lapse system, a series of images collected over 5-6 days.
I definitely agree with Alison on this, how she described it. And I do want to kind of look at your question in a slightly different way, which will probably make the answer much more obvious. And that is, do we want to move toward more subjective assessments, or do we want to move toward objectivity? And then the answer is quite straightforward. We don't want subjectivity. We want objectivity, and we want a certain level of standardization so that we can actually be able to predict outcomes more reliably, regardless of where we are in the world, which laboratory we're practicing in. And that, in the end, is to the benefit of the patient.
Explain to me how subjective it can be right now between embryologists versus the objectivity that AI and other tools by way of time-lapse provide activity for someone who's not an embryologist. For the business people listening, why is that significant?
We know as embryologists, when we look down the microscope at a blastocyst, at a late-stage embryo, it has a couple of main features, maybe 3 main features. It has a diameter. It has 2 cell types, the inner cell mass and the trophectoderm, but they can look broadly different. The diameter can change, it does. And we don't have a measuring tool down our microscope while we're looking. So you've got nothing really apart from your experience and what you've seen before to calibrate it on. It's just a really momentary assessment, and it's just so subjective because the lighting might be subtly different. There are other embryos might be around in the same field of view that could influence your opinion. You may have met the patient in the morning. Just so many human factors and different elements that could subtly but significantly change your opinion. Also, if you were to look at the same embryo half an hour later or half an hour before, or even 5 minutes, it can look substantially different. Doesn't very often look substantially different, but sometimes it does. So you may give it a completely different grading. And this grading consists of 3 letters or numbers. And based on that, big decisions are made. Is this embryo going to be transferred? Is it going to be cryopreserved? And then down the line, the following year, maybe if it has been cryopreserved, is it going to be warmed and transferred now, or shall I choose a different one? So it's such a simplistic assessment and momentary assessment that has major impacts on what's going to happen to that patient and even future decisions for that patient. So if you've assessed a group of embryos, you've given them these simplistic scores, which do relate to clinical outcomes somewhat. They're not absolutely useless, but they're very simplistic. But if you've done that, then that information could and will dictate what happens to that patient, and it could make or break whether they will have the baby they want. Many patients give up because they've not had a success first time with cryopreserved embryos still in the tank. So this is heartbreaking. Had we chosen a different embryo, potentially, based on our quick assessment, they may have the baby and they may go on to have another one from the same cohort. So it's, you don't want to put too much pressure on the embryologist, but it's a very important piece of their work.
Just to add on to what Alison was saying as well, and to bring it, Mina had made a comment about standardization between laboratories. And I think bringing time-lapse into more laboratories standardizes the tools that people have to evaluate. So in certain laboratories, they might only have a stereoscope to do their observations of their embryos, which the embryo features are not going to show up as much. You can't see as much detail, whereas other laboratories will have an EmbryoScope, which you can get a higher magnification. You can see more granularity in the cells. So their grading is going or could be vastly different. You think of looking at a picture that's extremely pixelated and trying to make a grade on that versus one that's high definition. I mean, we look at TVs, what we can see on the actors' faces are completely different nowadays because the resolution is so much better. So if we're looking at different technologies in different laboratories, evaluation of the same exact embryo is going to be different simply because of the resolution that you can see. So if you put time-lapse incubators in each one, there would be the ability to share pictures of that embryo. So even if grading genes are slightly different from laboratory to laboratory, the new laboratory that receives those embryos, if we're talking about transfer of embryos from one lab to the next, could look at the picture image and say, okay, do I agree with what the previous laboratory graded this on paper, or would I choose a different embryo based on the pictures that we have and the grading scheme and the way that we decide things internally, lab to lab. So I think that standardization would also be extremely beneficial on just the technology side.
Mina, tell me about the papers that you've been involved in with regard to research on the topic. Clinical outcomes being different with time-lapse versus with traditional incubators.
Right. So I think to some extent, the jury is still out on whether time-lapse microscopy and the use of this instrument actually leads to a significant improvement in outcomes. There have been many publications on that topic, and some will say yes, others will say no. Unfortunately, comparing these studies is actually quite difficult because they are heterogeneous in the design of the experiments or the studies, and also measuring the impact. Is it live birth? Is it cumulative live birth? Is it fertilization? Is it development? You have a whole spectrum of outcomes that have been assessed during these studies, many of which, if not most, are retrospective. There is this impression that we need more proof that this instrument will lead to improved outcomes. But, if I could just talk about it in a more philosophical way, and the way I normally talk to physicians to try to convince them that this is actually a good way to go, is that, it really takes more than a single technology to improve outcomes in IVF. And at this juncture, in 2025, the future really is about automation and standardization and integration of artificial intelligence in all aspects of IVF. And time-lapse is a step toward that future. In fact, that future is here already. We are seeing it unfold, although somewhat incrementally, we are seeing it unfold. So again, don't we need to question, do we need actually to question and move from subjectivity toward objectivity? And, in terms of looking at outcomes, is the technology being applied properly? Some people have it and just use it as an incubator, which is nice because it's a great incubator, but it's supposed to do more. You're supposed to use the data that it generates for development of algorithms that will help you better select your embryos. But if they are not using that feature, it's not going to be helpful to them, is it? And are the right expectations being set? You can't suddenly, using one instrument, improve your outcomes by 20 percentage points. It's just, especially in labs where good outcomes are being produced already, it's very difficult to reach that differential and fulfill that expectation. It's just not the right expectation. So you have to look at it holistically and looking at workflow, looking at environment for development of embryos, looking at the ability to select embryos more objectively, and looking at outcomes to see if you can improve incrementally. So this is how I look at it, but this is not exactly how it's presented very often.
Then why is time-lapse such an integral part of the holistic picture, Christine? You're opening a new IVF lab. Are we allowed to talk about that?
Yes.
You're opening a new lab. You've been managing your lab in Toronto. You're opening up a new one in Vancouver. From what I understand, you really wanted EmbryoScopes in that lab. One, is that the case? And two, if so, why?
Yes, that is the case. One, as Mina mentioned, it's a fabulous incubator. They're very sound. They work extremely well if you just use it as an incubator. From my experience starting the laboratory in Toronto, we opened in 2022. Most laboratories start with a small team, and we don't batch cycle, so they come as they come. And one thing that the EmbryoScope or a time-lapse incubator has allowed us to do is grow more naturally with less stress with a small group of embryologists. Your timing, you don't have to be as exact on timing for FERT checks in the morning, and being able to retrospectively watch how the embryos grow, one, gives you a great insight to how your culture system is doing, especially with an early stage laboratory. When you don't have a lot of cycles, you can spend a lot of time and look at optimization of your culture system based on the morphokinetics of your embryos, based on how they're growing, what's coming, your time points. We know that embryos can make it to a blastocyst, but certain time points aren't as ideal if they're not getting to the cleavage stage at a certain point, or the blastulation stage. Maybe there's things that you can tweak. So having that extra data and information to be able to analyze can really help. And I believe it helped us to get great success rates right off the bat. Also, with an offsite laboratory, having a time lapse is very helpful to be able to support from offsite. You can have somebody remote in and evaluate embryos together. If you have a new team or new embryologist, is a great training tool because you don't need to leave your embryos out longer. You don't need to be switching people at the eyepieces of your microscope to look at an embryo. You can look at it for 5 minutes and really dissect everything that you're analyzing and teach the people that are eventually going to be doing that as well. And having the ability to do that off-site is instrumental. And then also, we're really pushing for wanting to integrate seamlessly an AI system. Again, that's here and it's available. And that's something that myself and my team at Twig is very passionate about. And being able to do so seamlessly with a time-lapse incubator is necessary. And if we went with a benchtop incubator or box incubator, that integration is much more difficult, and we're right on the precipice of it. So why go with something that is going to be harder to advance into the future? Does that make sense?
I keep hearing about FERT checks and saving time, not having to do FERT checks at a certain time, and how important that is to embryologists, and they really like EmbryoScope for that reason. A business person might not understand what the implications of that are. Can you tell me more specifically, why do embryologists keep saying that as a benefit? What does that do? How does that impact the rest of the management of the lab?
So the timing of looking if eggs have been fertilized or not is very specific. There are what we call pronuclei that show up for a very small window of time, and that's how we know if the sperm has fertilized the egg. If you're looking at an ICSI case or where you inject the sperm directly into the egg, typically a fertilization check you would do between 16 to 20 hours post-fertilization or post-ICSI, because this is the most likely time point that you're going to see those two pronuclei, which is the morphological features that an embryologist evaluates to know if that egg was fertilized. So if you have a very early morning retrieval and you do your ICSI at 8 o'clock in the morning, that fertilization check is going to be happening at 4, 5, 6 o'clock in the morning. Getting embryologists into the lab at that time can be difficult. And if you miss those times of fertilization, because those two pronuclei, eventually they disappear. And then every egg looks the same. So if you don't see those pronuclei, then you might deem an egg unfertilized when actually you just missed it. In the case of conventional IVF, this window is a little bit more in flux because we don't know the exact time that that sperm entered the egg to fertilize that egg. So there could be a heightened chance of missing that sign of fertilization, whether you look at the egg too soon or too late. But with time-lapse, you're able to know exactly when fertilization happened, when those pronuclei appeared, how long they stayed, and when they disappeared as well. So it's very beneficial to be able to do those FERT checks and not feel as strapped for time of, I need to look at exactly this time point to make sure that I don't miss it. And Mina and Alison, please, you have much more experience than I do. Please add to this if you feel.
Yeah, you're quite right. It gives this flexibility. So how it can impact the wider team is that the lab can be more flexible. So if we need to schedule the egg retrievals at different times, we're not restricted by this specific window that we were before. So it has benefits throughout the whole clinic.
Did you want to add anything to that, Mina?
No, I agree with everything that was said. I do want to point out, though, that, even though the use of ICSI has increased significantly over the past decade or so, we still have somewhere between 30 and 40% of the cases that have standard insemination, and not all laboratories have switched to a 100% ICSI model. So in that case, you still have to stick with the timings and observe those requirements for fertilization check when eggs have been inseminated via standard IVF rather than ICSI. And those eggs are not put into the time-lapse incubators until the day or a day later after insemination, on day one, after fertilization has been checked already, and we know which eggs have been fertilized and which have not. So that caveat is still there.
It seems to me that probably only 10% of clinics, maybe 20% of clinics in the US have time-lapse incubators. I know that number's a lot different in Europe and in the UK. Is it that way in Canada as well, Christine?
The exact number, but I would say more and more clinics are adopting the time lapse in Canada. Whether they use it for all cycles or not is another question. I think there are some clinics who have a time lapse incubator and they use it for select cycles or select patients. But
Alison,
just anecdotally, I would say probably 50% have time lapse, if not more, in Canada.
That's many more than I would have thought. Alison, do you think we're at a tipping point in the U.S. now that you're part of a network that has a presence in the United States and you get to see a lot of the U.S. market? Do you think that we're going to see an upward trajectory of adoption, or is something standing in the way?
I don't see it being at a tipping point, to be quite honest. It seems to just be a really slow trickle to me in the US. So in the UK, we must be more than 90% of clinics, I would say, have at least one time-lapse device. And we've been using it at CARE Fertility since 2011, so it's such a long time. In the US, it seems to me that the primary embryo selection technique is PGTA, and that the mindset, generally speaking, is, well, this is superior in terms of embryo selection to time-lapse, so why would we need both? But actually, we know from the data and the evidence that we can distinguish between euploid embryos. So for PGT patients who are fortunate enough to have multiple euploid embryos, then let's add the time-lapse to really aid selection between them, just to get these marginal gains and give the patients the best possible success rate as soon as possible.
Do you think from the network seed, Alison, that it's possible for networks to test out time-lapse in certain labs? So if you have enough labs in your network, should every network have at least some of their labs with some EmbryoScopes, or how do you think about that?
Well, I prefer within a network to have a standardized best lab practice, so time-lapse in all of the labs. But saying that, it's not always realistic. They are very expensive. So I'd rather spread them out and have at least one in each lab than some of the labs being 100% time-lapse. And that's how we are at CARE Fertility. We don't have capacity for all patients to have time-lapse. So there is some selection and some patient choice there. But what we have done is use the knowledge that we've learned from the time-lapse systems over the decade or so to apply it to our standard practice. So we've learned, for example, that we really don't need to be disturbing the embryos from the standard incubator at all after FERT check right through to the blastocyst stage. So we don't make observations like we used to in the interim at the cleavage stage, just to see how they're getting on and try and anticipate how blastocysts will be. There is no point in doing that. And again, with the fertilization timing, we've learned, and we've published this, and it's fed into the new Istanbul consensus guidelines coming out soon, that to assess fertilization should be a bit earlier than we originally thought in order to maximize the chance of observing them in a standard system. So it has benefited standard practice, even if you're not fortunate enough to have time-lapse yourself.
So maybe this business case is part of what is a little bit of what I see, just as an outsider, is a bit of a divergence between the business side and the lab side. Because I have every embryologist on, I ask them a handful of things. One of the questions I go to every time, time-lapse a must-have or a nice-to-have? So far, everybody said must-have. And that even if they feel like, well, it could be a nice-to-have in these circumstances, now we think it's a must-have for the standard of care going forward. It seems to me like that consensus is firming in a way that wasn't even some years ago on the lab side, but yet at least maybe other countries have caught up on the business side. But in the U.S., they're still viewing that as, oh, all right, we have to judge that investment against other investments that we're making. You sitting in the network seat, Alison, owning equity in your company, how long does this take, if properly utilized, to return the investment? If we're buying a handful of EmbryoScopes, are we looking relative to cycle volume? Are we looking at a 3-4 year return on investment?
Well, it depends on the business model. I think what we've done is charge for using the time-lapse devices, for using the algorithms that predict outcomes. And we've had some criticism. I've had some criticism from some colleagues, scientific colleagues, because of course ideally, we don't want to be taking more money off our patients. We want to give them the best, most cost-effective treatment, the lowest possible price. But these devices are expensive. We made investment, big financial investment and R&D investment in them. So we have to charge a fee to use it. So we can get the return on that investment through the patient fees.
Tell me about the time savings and tell me about, I had Dr. Shankman on the podcast a month ago, asked her the same question. She said must have, and she had referenced a paper that I hadn't seen from UCSF of it's something like they think that they're saving the equivalent of one embryologist time per day. Anecdotally, what are you observing with regard to saving embryologists time or reducing their workload?
Well, I would say that if you use a time-lapse device in the typical way, let's say without any algorithms, automation, just a manual annotation, which is how we all started using it, then it will actually take you more time than not having it. So it increases the time required because you're looking at the embryos every day and you're annotating using the software that comes with the device. And on average, it will take 2 minutes per embryo. And most patients, let's say, have 8 to 10 embryos. So it'll take you 20 minutes. Whereas typically with standard practice, no time lapse, you may just make 1 or 2 quick observations and it may not take as long as that. But more recently, we've had the introduction of automated annotation. So the software is analyzing the development of the embryo, the morphokinetics, and generating that data, which is clearly taking much less time. So our own system, it takes 2 seconds. So we've gone from 20 minutes to 2 seconds. And that we invested, it cost us about £1 million. And we've talked about this before, Griffin, but that £1 million was really well spent, I would say, because we've got a singing and dancing system that's saving 6 months of embryology time across our network.
Christine, you've got partners. Your REI partner is Dr. Rhonda Zwingerman, and then you've got business partners, Tanner and Zach, 2 Bay Street entrepreneur, finance, business guys. Besides being really good guys who listen to their teams, why did they go for your proposal when you said, I really want EmbryoScopes in Vancouver? Why did they go along with it?
I mean, this is extremely multifaceted, and we're only going to scratch the surface of it. One is the standardization across laboratories. Alison already mentioned it. She has vast experience with running a network. It's much more difficult to run laboratories when their procedures are extremely different. And that goes down to the equipment that's being used. The protocols for using a time-lapse incubator versus a benchtop or a box incubator are very different from, as Mina mentioned, the dishes that you use and how you prepare those, as well as the daily observations and how you have to work with that, as well as how you have to work with other equipment in your laboratory and what gets used at what time. So there's the standardization aspect. There's the aspect of us wanting to standardize the use of AI for assisted embryo evaluation. One thing that we're evaluating, as Alison mentioned, is potentially taking out day 3 observations, which then would correlate to saving a lot of embryologist time because that's 1 full day of observations that are not going to have to be done. Being able to use assisted calling helps to reduce that time. We do use assisted calling in our laboratory in Toronto, and it works extremely well. And it's very beneficial for the patient. We also believe, myself and I'll put Dr. Zingerman in here as well, that the time-lapse incubator is a phenomenal incubator for the embryos, and where we don't have a large study showing that there is an increase in pregnancy rate due to the undisturbed culture, we do believe that there is an incremental benefit to our patients because of that. And to be able to expand that over to our new laboratory in Vancouver is necessary. Additionally, with the EmbryoScope itself, the space savings in the laboratory is very helpful with growth of the laboratory. And because you can fit so many samples in a smaller incubator. So it fits 15 patient samples in there, 16 samples each dish. So to maximize the space or the usage of square foot in the laboratory, this for us was the most beneficial time-lapse incubator to have.
That topic of scale makes me think of everything that David Sable has been talking about, everything that patient advocates have been talking about, that we're a field of medicine that has a cure for people. I'm paraphrasing Joshua Abrams, who might be paraphrasing someone else, but putting it in these terms has lasered my focus of that we have a cure for a disease that strikes people in the prime of their lives, but we don't have a delivery mechanism that delivers that to patients at the level of population health. And I look at the investment coming in, and I look at the companies growing, I look at the political climates, and I don't see the status quo as acceptable for much longer. We are seeing people demand much broader access to IVF. I believe that they will get it both through the markets and through legislation. It sounds like that the standardization provided by time-lapse is a big ingredient. Can you tell me about and this is for any of the three of you, why this is so important for scale?
I think it's all about the data. For me, if things are standardized, you can be more confident in the data that's being generated. And so we don't have all the answers. And one of the main reasons that we went for time-lapse was to get a better understanding of how the embryo develops and to help us collect data in order to make some more informed decisions. Yeah, I think that for me is the main. So it's scalability in order to generate the data, in order to plow it back into continuous improvement.
I think that's a very important point that Alison just made. I mean, we live in an information age, and big data and more of our decisions are data-driven. And so it only makes sense that we would do the same in the embryology laboratory and push for data, more and more data, and the analysis of the data, which will eventually actually help those who may not have contributed the same amount of data to this analysis. We want others to benefit from the data that Alison collects and so meticulously analyzes. A great example is actually the paper on checking fertilization, and how many laboratories may be doing this 1 hour later than they should be checking fertilization, therefore ending up with these, unfertilized embryos, which is a complete misnomer, and it's a misinterpretation of what has actually happened. So we are benefiting, the community at large is benefiting from all the data that were collected in Alison's laboratories and were in turn analyzed. And a conclusion was made that is relevant to everybody, all practitioners in the field. And that's very, very important. And I think that this discussion with the people who hold the purse and about cost and benefit, it really has to shift. It has to shift from a focus on pure, what's the profit in it, and are we getting amazing increases in pregnancy rate? So what is it we're achieving here? And is that important to the program as an individual program, but also to the field and to all the patients as a whole? And the answer to that is yes, it is to the benefit of the general population of patients as well as clinics that are doing IVF. So the more data we have, the more power we have to make the right changes, to choose the right direction. So I don't subscribe to this very narrow interpretation of what these add-ons, which I don't use that terminology. I'm just using it as to illustrate my point. This very narrow ideology that if time-lapse microscopy has not been shown to lead to major increases or significant increases in pregnancy rates, then it's an add-on, it's unnecessary. I just don't subscribe to that vision and that idea. IVF has improved since the 1980s, and I don't think there's anyone except for perhaps one person who will remain unnamed. There's agreement that IVF has improved incredibly over the past 4 decades or so. And these improvements have been incremental and due in large part to the changes and innovations in the lab. And so we have to look at time-lapse and other tools in that specific context, rather than saying, well, does it improve pregnancy rate? What? It doesn't? No, we're not interested. It's an add-on. It gets a red light. It gets a orange light, or, I just don't see it that way.
For those that are interested in exploring this more, I think Vitrolife is offering a 4-month free trial for EmbryoScopes for eligible labs, and they'd have to check who's eligible. Well, I'll put some info in the show notes, but provided that a lab is eligible, Vitrolife will give them the EmbryoScopes, install them. If labs are eligible for that, one, should they take advantage of that? And if the answer to that is yes, how should they take advantage of those 4 months?
I would say always take advantage of a nice piece of kit being offered to your lab. It's a privilege to have time-lapse in the laboratory. It's a privilege to watch the embryos developing. Yeah, I think the advice would be geek out, read the papers, talk to experts, use it properly, collect the data, show your patients their beautiful embryos developing, and embrace it. Why not?
Mina, Christine, would you give people any tips of try to learn this, or try to obtain this information, or try to test this workflow, or anything what tips would you give to someone during that 4-month period?
I think that bringing time-lapse technologies into the lab is not trivial at all. It's nerve-wracking. At least it was for me. And I always show these stages of dealing with incorporating the technology. At first you have sticker shock, and then you are euphoric that it's there, and then you are pulling your hair out because you're seeing things that you've never seen before in embryos, and you're saying something is wrong, what's happening, and you need therapy and all of that. And then you pass that stage and you go into this, wow, what a tool. And I went through all of those stages, and I suspect that other people will too. And if you can get help avoiding some of the more unpleasant aspects of that integration, then I think you should. If the company is offering to help you establish the technology in your laboratory and integrate it in the right way, I would go for it. The more help you get, the easier it becomes. It's not easy. Don't expect it to be easy, but it does get there. And the more help you have before you get really involved with patient material, the better it will be.
People always seem to say EmbryoScope like Q-tip. Like, we don't say cotton swab, we say Q-tip. And I know there are other time-lapse incubators out there, and they might be pretty good, but it seems like there's a general preference towards EmbryoScope. For those of you that use EmbryoScope, why EmbryoScope as opposed to a different incubator? What was it that you were dealing with that you preferred EmbryoScope for?
Well, we chose EmbryoScope really because it was the only one available at the time. And once you've got one system in, it's especially across a network, and you've got your protocols and you've got the data collection, and it's all working seamlessly. It's quite hard to change. Saying that, we do have Jerry time-lapse incubators from Genea as well now, because we've acquired clinics that have had them, or we've decided to evaluate. We look at both systems, and they're similar, but they're also different. And the main difference, I would say, is the humidification in the Jerry, whereas EmbryoScope is a dry incubator. So I don't think there's much between them. It's great that there is competition and that we do have choices, and there are others also available.
Well, to your Q-tip question, one, I think EmbryoScope is one of the first ones out there, so it caught on. Also, they hit the name very well, EmbryoScope, a microscope for embryos. I think it kind of tells exactly what a time-lapse does in more layman's terms. So I think that is very catchy and easy to use. In regards to our decision to use the EmbryoScope or to go with the EmbryoScope, a lot of it went down to, one, the reliability of the incubators. I think the Jerry also has a very reliable incubator. It's very good, very sound. I think Miri as well has a time-lapse incubator. But for us, was the square footage and how many patients we could fit into a small area. We built a laboratory in a city. We're building a new one in a new city. Real estate is expensive and you don't have a lot of it. So we don't have the space to grow in the laboratory, or we don't have infinite space in a laboratory. And the overhead's already very expensive. So if we're able to fit 15 patients in a, about 18-inch by 18-inch area on a bench top versus something that's 1.5 times that size, for the same amount of patients, for us, that was the cost per square footage.
How important is it to be able to have quality control and do quality control in one chamber for 15 dishes as opposed to having multiple different chambers?
Yeah, I think the engineering and design of this particular time-lapse incubator really quite impressive. That's maybe partly the reason for the name EmbryoScope being used as sort of generic for this type of incubation systems. They were also the first, if you don't count EVA, which was a very different concept, although it did the same. It was the same idea, but it wasn't an independent incubator. So they were the first. And very often this happens. That name then becomes generic. In terms of quality control, I think, yes, there is an advantage to having a larger number of patients in the same incubator so that you're focused on that one incubator to QC rather than 10 different incubators to QC. But I'm not sure if I see that necessarily as an advantage, at least in the context of regulations in the United States. I think our problem is that those regulations are actually outdated. In the EmbryoScope, a system that is monitoring continuously all the conditions within the incubator. Yet, we are obliged to use external instruments that may or may not be as accurate as the instrument itself, to double check to see that those values are within range. So, the EmbryoScope is such a sensitive piece of equipment, and also, in my experience, very, very stable. So all this fiddling, trying to measure this and measure that external to the incubator itself may actually be not only superfluous, but it may backfire at some point. So I think there are issues, the other issue is that, okay, you're collecting all of the data. All the data are being collected by the instrument itself, but very often there is no connection to your EMR. So you have information, enormous amounts of information that are being collected separately. And you have to still go into your EMR and enter data by hand on development of the embryos. So there are issues like that that need to be resolved, and in some cases may have been already resolved. Yeah, is an important aspect. And I think that because of the stability of this system and because it continuously records it's the conditions of the incubator, that is helpful.
For any or all of you, what should people consider about time-lapse incubation that I haven't asked you about?
I think we haven't talked about how you use it and how you would choose the embryos and how you can be confident that you're doing that correctly, especially if we're thinking if we've got potential new users listening. It could be quite daunting. Do they just, because it could be just plug and play, but if it is plug and play and that plug and play provides you with an automated assessment and grading or score for each embryo, then how do you know that you can trust it? And that's quite a daunting prospect for new users. So the advice would be to validate in-house, as with anything else. You can say, okay, the machine says this is the best. You either agree or not, but record when you agree, when you don't agree, what you do if you don't agree, and try and then tally up all the numbers and see if it's better than you and if you can embrace it wholeheartedly and use it, trust it completely to do the choice for you, because that is quite a leap of faith, I would say, for new users, especially if you're relying on an algorithm or a system that you've not built yourself and you don't really know how it's been built. So ask questions and take it, enjoy it, enjoy the ride.
I would say that, like I said before, it's not easy. And like Alison said, it's not quite plug and play. You need to invest the time and energy, and you need to collect the data and decide how you are going to be selecting embryos if you don't have the automated version, which I'm not sure if in the US that embryo selection feature is available yet. So you may not have that. And if it costs additional dollars for that, people may shy away from it. So you need to work it out. And I think Alison said it very nicely, that you need to think about how you're going to validate it. You need to know how you're going to use it. You need your own protocols. It is not from lab to lab. It may be different. We still have not really found algorithms that are universally applicable. And so it takes work. You have to expect to work a little bit before you feel comfortable and confident about using the system for embryo selection.
I'll just add in here to sum my opinion up. I think the EmbryoScope and time-lapse incubators are a phenomenal tool to be able to elevate a lot of embryology labs. Is it essential at this time for all embryology labs to have it? No, I think the laboratories that don't have time-lapse also have great fertilization and pregnancy rates. And like we've mentioned before, is a time-lapse incubator going to make that jump up exponentially? Not at this time, but every incremental bit helps. And I think to move forward into kind of the next frontier of IVF, the time-lapse incubator is going to be essential, and it's going to be necessary to be able to seamlessly integrate AI-assisted calling or assistance in the laboratory in a very smooth and trouble-free manner that's not going to take a lot of time to do that and a lot of embryology time. I think the information that we're gathering, like Mina had mentioned before, is bleeding into all laboratories and just the standard of care that we're able to give our patients, and to be able to move the standard of time to pregnancy to decrease that. We're learning a ton of information from these laboratories that are able to collect this data and are able to share it. So I think time-lapse incubators are essential to our field. I think that they're going to become more and more important. And I urge the vendors to help develop payment plans for laboratories who might not be able to make that one-time payment, to make it possible to get it into their laboratories. Initiatives to be able to support research with AI being, or not AI, maybe AI, but with time-lapse incubators to support or offset the cost of the incubator can be essential to get that integrated kind of into the laboratory. But if you can make that payment plan, so it's a year or 2 years, build it into the cost of supplies, get more creative with the ability to get those machines into the laboratories, I think it's going to benefit everybody. So you just got to work together.
Alison Campbell, you're becoming one of my favorite people in the field as we get to know each other more. Mina Alikani, we will someday. You will be one of my favorites too, I have a feeling. Christine, you've been one of my favorites for a long time, Christine, and I am honored to have all three of you. Thank you for coming on the Inside Reproductive Health podcast.
Thank you very much.
Thank you.
It's been such a pleasure, Alison and Mina. I feel honored to be able to be on this podcast with the two of you. And Griffin, it's always a pleasure. So thank you so much.
Today's episode is paid content from our feature sponsor, who helps Inside Reproductive Health to deliver information for free to you. Here, the advertiser has editorial control. Feature sponsorship is not an endorsement and does not necessarily reflect the views of Inside Reproductive Health. Thank you for listening to Inside Reproductive Health.